Hello guys, welcome back to another lecture of radiology. So today in this section we are going to discuss about the important imaging features in trauma. So this is a very basic topic, but definitely one question is definitely going to come from this topic and you should know this topic by heart. So let us begin. Now guys, in all cases of trauma, we all know what is the investigation of choice. So for every patient, we are going to get a non-contrast CT scan done of the head, right? Now the question is, do we get a CT scan done in every patient? No, we are not going to get a CT scan done in every patient with head trauma. So there are few conditions. Now, American College of Radiology, it has divided the traumatic brain injury into three types. One is mild, you have moderate and severe. It is based on the Glasgow Coma scale. So if the score is between 13 to 15, it is a mild traumatic brain injury. If the score is between 9 to 12, it is a moderate traumatic brain injury. And if the score is less than 9, it is a severe traumatic brain injury. So according to ACR, you are going to get a CT scan done only in patients with mild and severe traumatic brain injury. Sorry, in moderate and severe traumatic brain injury. In mild, you are not going to get a CT scan done. But there are few cases in which you will get a CT scan done in mild traumatic brain injury also. So these cases include patients with age more than 60 years, patients having complaints of vomiting, focal neurological deficit, post-traumatic seizures, any history of intoxication, any coagulopathy in these patients, right? So for these patients, you are going to get a CT scan done. Now the question is, how to identify a bleed in these patients? So guys, general rule is that the bleed appears hyperdense on the CT images, right? So if you look at the various types of bleeds that are shown here, you will see an area of hyperdensity. Okay, so this area of hyperdensity is nothing but an area of hemorrhage. So there are two things which appear bright on CT. One is hemorrhage and the other is calcification. So definitely if we are having an history of trauma, we are going to suspect hemorrhage. Also they have different Hounsfield units, right? So calcification will have Hounsfield units more than 300, whereas hemorrhage will have Hounsfield units between 80 to 100. So that is the difference between hemorrhage and calcification, right? So we have discussed how to identify a bleed. Now let us see how to classify the bleed. So bleed can be classified as extraaxial or intraaxial. So what do you mean by the terms extraaxial and intraaxial? Intraaxial means that the bleed is present within the brain parenchyma, and extraaxial means that the bleed is present outside the brain parenchyma, right? So extraaxial bleed, what you will see, there are three types. One is extradural hemorrhage, then you have subarachnoid hemorrhage, and you have subdural hemorrhage. So these are the three types. Now how to identify an extradural, subarachnoid or subdural hemorrhage? So all these bleeds, they have characteristic shapes. So if you look at the extradural hemorrhage, so it is going to have a biconvex shaped or a lens shaped. If I talk about subdural hemorrhage, it is having a concavo-convex shape. And if there is hyperdensities along the basal system or sulcal spaces, you are going to suspect a subarachnoid hemorrhage. Now another important feature that you see in extraaxial bleed is there will be no edema, right? Edema will not be seen in patients with extraaxial bleed. And if I look at the intraaxial bleed, all the intraaxial bleeds, they will be surrounded by a rim of hypodensity, and this rim of hypodensity is nothing but edema. So let me show you how does this edema looks on the CT images. So this is another patient with road traffic accident. You can see that there are hyperdensities, right? And these hyperdensities, these are surrounded by a rim of hypodensity. So hyperdensity surrounded by a rim of hypodensity means these are axial bleed, or we can say these are hemorrhagic contusion within the brain parenchyma. Now let us study each of these bleed separately. What are the various causes, right? What is the source? Why they have particular shapes, right? Now talking about this patient, so we can see that in this case the shape of the bleed is biconvex, and biconvex shaped bleed, I have already told you, it is seen in patients with extradural hemorrhage. Now we should know what are the clinical features. So these patients, they will present with lucid interval. So what is lucid interval? The patients will be unconscious at the time of injury, right? Then they will again regain consciousness for a momentarily or for a short period of time. Then after regaining consciousness, they are again going to lose their consciousness. They are again going to become unconscious. So this is the period in which the patient is becoming conscious. This is known as lucid interval, right? This extradural hemorrhage, it is also given one name which is known as talk and die syndrome. So the patient is talking to you normally, and then suddenly the patient dies, right? This is the clinical feature. Now what is the source of bleed in extradural hemorrhage? It is due to the rupture of middle meningeal artery, right? Now what happens? This extradural hemorrhage is biconvex because it is outside the dura. Extradural means this bleed is outside the dura, and we all know that dura mater is firmly attached to the skull, except at places where there are vessels traversing within the dura mater, right? So whenever there is a bleed within the dura mater, so it is going to splay the dura mater, and that splaying of the dura mater, it will result in a biconvex shape. Now we should know that this extradural hemorrhage, okay, it is never going to cross the sutures. So this is a very important point you need to remember. So if a bleed, you are not able to identify the shape of the bleed, but the bleed is crossing the sutures, it means it is not a extradural hemorrhage, right? But it can cross sagittal suture. So this is one point we need to remember. right? So these are all important points related to extradural hemorrhage. Now coming to the next type of bleed. So this type of bleed, it is common in old age patients or in alcoholic patients. So what happens? That due to atrophy of the brain in old age patients, there is stretching of the cortical bridging vein, and when there is stretching of cortical bridging vein, it results in subdural hemorrhage, right? Now we can see that the shape of this bleed is concavo-convex. So we all know that this concavo-convex shape bleed, it is seen in patients with subdural hemorrhage, and we have already discussed it is due to the rupture of the cortical bridging veins, right? So now talking about the shape of the bleed, right? Shape of the bleed is concavo-convex because outside there is a dura mater, inside it is taking the shape of the brain parenchyma. So what happens? The dura mater will not be compressed, and this brain parenchyma, it is taking a concave shape, and that is why the shape of the bleed is concavo-convex. And one more point is that venous, it is a venous bleed, and venous bleed is going to have low pressure. Because of the low pressure, this shape of the bleed becomes concavo-convex. So these are all important points: cortical bridging veins, old age patients, alcoholic patients, concavo-convex shape bleed, right? And patient can present with headache, right? Now here in this image, besides the shape of the bleed, one more thing that we can see in these patients is that there is a hypodense area, right? And there is a hyperdense area. So two types of densities can be seen within this concavo-convex shape bleed. ठीक है? So because why are we getting this two types of hyperdensities? This is because any hyperdense area, it is a acute hemorrhage, whereas any hypodense area, that is a chronic bleed. Okay, so if I have to make a diagnosis for this image, it is a acute on chronic subdural hemorrhage, right? Acute on chronic subdural hemorrhage. Again in this image we can see that the shapes of the bleed, it is concavo-convex, right? And besides the concavo-convex shape of the bleed, we can see that there are hyperdensities in the lower part, and a hypodense collection can be seen in the superior part. So these two types of densities, these are seen in patients with acute on chronic subdural hemorrhage, right? Now talking about this case, so here in this case we can see that the hyperdensities can be seen along the Sylvian fissure, along the supraorbital cellar cistern, Sylvan fissure, supracellar cisterns. So basically hyperdensities are seen along the basal cisterns. So these basal cisterns, these are formed of subarachnoid spaces. So when there is a hyperdensity in the subarachnoid space, it means that it is a bleed in the subarachnoid space, which is known as subarachnoid hemorrhage. Right. Now there is a bleed in the subarachnoid space, which we call it as subarachnoid hemorrhage. Okay. Now what will be the clinical features in these patients? So they will present with worst headache of their lifetime. And what is the cause of the bleed in these patients? It is due to the rupture of berry aneurysm. Right. So this is subarachnoid hemorrhage. I hope extradural, subdural and subarachnoid hemorrhage are clear to you guys. Now guys, we have discussed that in patients with head trauma, investigation of choice is NCCT head. But there is one exception to this rule, and that is diffuse axonal injury. So these patients will have clinical features of non-improving altered sensorium, and besides altered sensorium, okay, these patients will have history of road traffic accident. And the third important point in these patients is NCCT head can be completely normal in these patients, right? So these are the three important features in patients with diffuse axonal injury. Non-improving altered sensorium, history of road traffic accident, and you have an NCCT head which is completely normal. So सर आपने ये बता तो दिया कि NCCT head normal है, altered sensorium है, then how do you diagnose? What is the investigation? Investigation of choice is MRI, and within the MRI you will have gradient echo sequences which are going to identify this bleed, right? So what you will see on the gradient echo images, there will be foci of dark spots, and these foci of dark spots can be seen in regions of gray white matter junction. They can be seen in brainstem, in corpus callosum. So these are the three main areas where these black spots can be seen, and these black spots are nothing, these are foci of hemorrhages. And these foci of hemorrhages, they appear dark on the GRE sequence, and we call it as blooming foci on the susceptibility weighted images or gradient sequences, right? So what happens whenever there are shearing forces? The neuron, it breaks at the junction of its body with the head, okay, at the junction of the filament with the head of the neuron. And whenever there is injury at this point, there is a focus of hemorrhage at that point, and that focus of hemorrhage can sometimes be seen on the NCCT head, where it can appear as petechial hemorrhages. Sometimes can be seen on the NCCT head appearing as petechial hemorrhages, and most of the times the NCCT head is normal, and on SWI images you will see foci of blooming, right. This question is again was asked in your NEET-PG exam, right. So that is why it is important also. Now coming to the next question or next image. So what are you able to identify? This is a spotter. So this is a case of leptomeningeal cyst, okay, or growing skull fracture. So what happens? There is a skull vault fracture, and through that skull vault fracture what happens? There is herniation of the meninges as well as gliotic changes, herniation of leptomeninges, and the underlying gliotic changes will also herniate. So this is known as growing skull fracture, right, or leptomeningeal cyst. Another very famous sign that is again asked in many exams. So what are the two things which appear black on CT? One is air and the other is your fat. So here we can see that there is something black which can be seen in the extraaxial spaces, and this black collection along the extraaxial space, it is nothing, it is but air in the extraaxial space, and air in the extraaxial space is known as pneumocephalus. So basically air is entering your cranium. So now the question is, how is this air entering the cranium? So this cranium is entering through a fracture of the paranasal sinuses, and because of the fracture of the paranasal sinus, air enters the cranium and it causes mass effect. It pushes the brain parenchyma, and while it is doing so, it is taking the shape of Mount Fuji, and that is why it is known as Mount Fuji sign, right, of pneumocephalus. Now this is another CT shown to you. And what are you able to see on this CT? So before discussing what you are able to see, I will tell you what is the clinical history. So the patient has history of road traffic accident. Along with that, the patient has history of chemosis and pulsatile exophthalmos. Now question is, what is the diagnosis, right? So if I look at these images, we can see in this patient that this is the superior ophthalmic vein and this is your cavernous sinus. So if you will just look at the normal images, you will appreciate that this cavernous sinus as well as this superior ophthalmic vein both are enlarged cavernous sinus and superior ophthalmic vein. Now this is happening because there is increased blood flow within the cavernous sinus, and we all know that superior ophthalmic vein drains into the cavernous sinus. Because of the increased flow in the cavernous sinus and superior ophthalmic vein, right, what happens? This is occurring because of the formation of fistula between internal carotid artery and cavernous sinus, known as carotid-cavernous fistula, right? So basically a fistula is forming between the internal carotid artery and cavernous sinus after trauma, and because of this there is arterial flow in the cavernous sinus as well as superior ophthalmic vein, because of which what happens, there is pulsatile exophthalmos in patients with carotid-cavernous fistula, right? So guys, in the basics of radiology we have discussed the different windows. So here in this image we can see that this is the bone window image. So here I just want to tell you briefly that besides picking up hemorrhages, okay, on the NCCT head, another very important indication to get a CT scan done is to pick up fractures, which are again very well seen on the non-contrast CT. So here in this patient we can see that there is a fracture involving the right parietal bone. So just remember this thumb rule, which I am going to repeat very repeatedly. If you have to look for any fractures, then again NCCT is the investigation of choice. If you have to look for any air within any part of the body, whether it is mediastinum, whether it is lungs, or whether it is abdomen, so again non-contrast CT will be the investigation of choice, right? Thank you guys.